Ciao, Ferwerda JD. That's my Vietnamese. Today I'm going to have a talk about diabetes in the eye. Although it's going to be including some basic stuff, I still think it's always necessary to go back to the basics in order to present all the option therapies that we have nowadays. As specifically, the reason I'm talking about this is because diabetes type 2 is on the increase in Vietnam. If you do some studies shown that about 5.4% nationally of all the population have diabetes type 2, and especially in the south the prevalence is much higher. These are estimates. Some studies have suggested that the numbers might actually be much higher. I think that might be right because most cases nowadays that present themselves, they say they have diabetes for 5 years, but judging on their symptoms that we see in the eyes, they probably have it much longer. Also, epidemiology suggests that these numbers will rise because of changing dietary habits. Why does diabetic retinopathy, why does diabetes affect the eye? Because in the eye we're dealing with end vessels, like in the kidneys, in the hands, and the feet. They're all the primary organs affected by diabetes. This is the cascade, the mechanism of events. First, diabetes affects the blood vessels, narrowing of blood vessels, reducing the perfusion, leading to ischemia. Ischemia triggers a VEGF release, which in turn stimulates the growth of microaneurysms. That leads to neovascularization, hemorrhages, formation of membranes, and then the end stage fractional retinal detachment. In order to understand diabetes well, you have to classify it and not only understand but also treat it and diagnose it well. You have to adhere to a single classification. If you mix and match and do it, you're going to give the wrong treatment to the wrong patient. So a common classification is very important. First classification, no apparent abnormalities. So you have a normal, this slide shows it, the top picture is a normal retina. What is the protocol in these cases? You check them every year and advise always good general management. There's one point that most doctors sometimes, a lot of doctors sometimes forget. It's not just the eye we're treating a whole human being, and it does help to have the patients with a good HbA1c instead of a patient with a HbA1c up beyond 10 or more. So motivation of the patient is extremely important. It's a picture of the normal retina again. Mild non-proliferative diabetic retinopathy. So normally what we can see is a few microaneurysms and no other signs. Vision still 20/20. What do I do normally and what is the protocol internationally is check them every 6 months and give them good advice again. You can see some microaneurysms. Moderate stage 3, non-proliferative still. There are just more than a few microaneurysms visible in multiple quadrants, not just in one quadrant but in multiple quadrants. Normally what I do and what most protocols recommend is do a baseline OCT so you can follow up in the future. It's always handy to have an old picture there to see what you saw last time, because if you just describe it on paper you cannot remember. Do pictures, do an OCT, and follow up increases to 3 to 4 months. Again, motivate your patients. If they don't come back, then the next stage will be worse. It's a picture of moderate. You can see some more aneurysms. Severe non-proliferative. So now we're getting the whole complex except for the neovascularizations, etc. So microaneurysms, exudates, intraretinal hemorrhages, macular edema. Normally what we do, if we don't see any neovascularizations, I do recommend doing an angiogram at this stage, just to judge the perfusion of the retina, and of course a baseline OCT again. If there is non-perfusion on the picture, on the angiogram, I recommend treating the non-perfusion area with laser and treat macular edema with anti-VEGF. We're going to go back to this point, treatment with laser versus anti-VEGF, because that's the hot topic nowadays. I don't think it's and or, but we'll come back to that. At this stage, always, I also recommend patients to do a good general checkup again. If they are not compliant, if their HbA1c is high, I recommend them checking up with a general specialist, a endocrinologist, to get their diabetes under control. Again, motivate your patients. You threaten them with blindness if they don't comply with all the treatments if necessary, but get them to comply with their diabetes care and their ophthalmology checkups. So these are pictures of severe non-proliferative diabetic retinopathy. It's another one. On some of these pictures you can already see some neovascularization in the bottom one there. Some neovascularization visible. Nose T of exudative macular edema. You can clearly see the exudates and the edema, of course. Exudative macular edema, you have several treatment options. You have anti-VEGF, Avastin, Lucentis, Eylea. It's always important to prepare patients for long therapy. Sometimes they expect results after one injection, which is not going to happen in most cases. It's going to take some prolonged therapy, so prepare mentally for longer therapy. Tell them you're not going to get one injection, tell them you're going to get first 3 injections according to your protocol that you're using, and then maybe after 3 months we're going to extend the treatment and do more injections, depending if you have improvement. Another treatment option is focal grid laser. It's not one of my favorites anymore. Intravitreal paraglobal steroids does work. Improved general compliance. It is described in literature, and it is, in my experience, increasingly important that we stress that our HbA1c is under control. I have seen cases where I gave treatment for over a year without improvement, and then suddenly the patient realized that he had to change his diet, and he started improving his HbA1c below 6, and the macular edema decreased remarkably. So it does help a lot in these cases. This is point 5, is a point of discussion. It is still performed in Europe in some places. I don't think it's being used in the US that much, but an ILM peel in cases where you have dense macular edema, dense clusters of exudative macular edema, then an ILM peel might be a solution. Nowadays, like I said, option 2 of focal grid laser is permanent treatment with scarring. Does leave a lot of side effects like scotomas in the central visual area, so it's not one of my favorites anymore. Nowadays, most doctors will choose either option 1 in combination with option 4 to get the results necessary. Option 2, focal grid laser, only if all other options fail. Proliferative DRP, where it says itself, is with neovascularization. If your visibility is good, let me go one slide ahead and show you a nice image of a severe proliferative diabetic retinopathy. I saw one of this today in a consultation. If the visibility is good and the retina is attached, then pararetinal laser can still be performed. Of course, if you have tractional retinal detachment, you need to do surgery. Or if visibility is poor, if they have a hemorrhage, you cannot do laser, of course. The role of anti-VEGF in proliferative diabetic retinopathy is slightly controversial still, in the sense that it's not recommended as a monotherapy. Once you have neovascularization and you start injecting anti-VEGF into the eye, if one way or the other the patient interrupts his treatment and can't continue his treatment on a regular basis, what you're risking is an offshoot of VEGF response, which increases the risk of severe neovascularization and tractional membranes. So if you have active proliferative diabetic retinopathy, my recommendation is don't do monotherapy anti-VEGF, do it in combination with another therapy like retinal photocoagulation, or if you plan to do surgery, you can do anti-VEGF before you do your surgery to calm down the eye. I'm going to stress this point one more time because I have seen it in the past. In the early stage when we started using anti-VEGF, we experimented a lot, and we saw quite a few people who, one way or the other, didn't show up for their repeat injections, and then they came back after 3 or 4 months with an explosion of neovascularization and hemorrhages, and it was just a big mess. So, anti-VEGF only in combination with another therapy in this stage. Motivate the patient again. If you're at this stage, it's going to take a long time to get them back on track to improving their vision. So try to keep them in your therapy. Where am I now? I did something wrong. Okay, here I am. So that was this picture. This is another picture of severe. You can clearly see around the arcs, you can see all your neovascularization. This is a patient who still has activity, but you can see peripheral, there's still some areas of non-perfusion. This is a nice picture that shows proliferative diabetic retinopathy. You can see the picture of the surgery, and you can see a post-op pic, how it looks after the surgery. Don't underestimate sometimes if they are this severe, if their perfusion of the macular area is poor, their vision will not recover as much as you expect, although anatomically it looks very nice. But still, this is preferable to the picture A. This is another overview. What to do. Stage 1, no apparent signs, just check once a year and motivate your patients. Don't need to do any further diagnostics. Stage 2, increase your frequency of checkups to every 6 months. Still no other diagnostics necessary. At stage 3, we start doing a baseline OCT. Stage 4, OCT and FFA. If necessary, laser anti-VEGF. And stage 5, we're starting to think about surgery. Now, this is a nice slide. I found this online, and it clearly states what the effective, and here we start discussing about laser versus pararetinal photocoagulation. These are randomized studies done by the Diabetic Research Network, and they clearly show that when monotherapy, PRP, is chosen, best corrected vision increases only by 0.2 letters, whereas with anti-VEGF Lucentis, it increases 2.8 letters. Visual field decreases apparently with pararetinal photocoagulation. This is one of the main complaints about PRP. DME only decreases by 28% or 28% of all patients still have DME, whereas with the anti-VEGF only 9% still have DME. And in about 15% of cases, a vitrectomy was necessary after PRP, and in the anti-VEGF group only 4%. Now I must state, these studies were done with a compliant group, so no dropouts, etc. This is extremely important. In order to be able to compare these two groups, you must know that the compliance in the second group, the anti-VEGF group, was maximum. So there are no dropouts and no surprises there. The treatment sessions necessary for PRP were 1 to 3 sessions per eye, and that's one of the disadvantages of anti-VEGF, is they needed 10 to 14 sessions over 2 years. Endophthalmitis was only present in one case in the anti-VEGF group, but no, of course, in the laser group. And the number of visits, you can see the difference. A patient with PRP needed less visits than the patients who got anti-VEGF. A big number below is the cost. Laser is a fixed therapy, and when you're done your PRP, you don't need to do more laser, so the costs were much lower than in the anti-VEGF group. Now, what does it bring us nowadays? A lot of doctors agree with me when I'm telling, okay, you know, nowadays hardly ever do we choose a monotherapy. We choose a combination of the two. And that, I think, will bring us the advantages of the anti-VEGF group and some of the advantages of the PRP group. So it's the best of both worlds. I think more and more we're looking at, when we choose what direction we go, do we do laser or do we do anti-VEGF? Depends also on the perfusion. If there's severe non-perfusion, I prefer to add laser to the mix and not do just anti-VEGF monotherapy. When you do expect, when a patient lives far away, cannot come to you easily, and might drop out of therapy, do more laser, lean more towards the laser than to the anti-VEGF. And of course, monetary problems, if somebody doesn't have the money to comply with anti-VEGF therapy, do laser. It's always preferred to do laser than to do nothing. This is another point. This is a question I always get when I'm visiting colleagues. What do I do if I have a diabetic patient and I have vitreous hemorrhage? Of course, always do a B-scan. It's logical to do a B-scan and see what is behind the blood. I always ask, I start asking, what are the risk factors? Does the patient take aspirin? Does he have high blood pressure? Does he have any other reason than diabetes for getting the hemorrhage? Because you wouldn't be surprised if sometimes you find a patient who has a vitreous hemorrhage but doesn't have DRP causing it. It might be a retinal tear with a retinal detachment. So, always look at the partner eye. If the partner eye is completely clean, yes, I'm always more cautious about what's behind there. So a B-scan is extremely important. Then the golden question I always get, how long can you wait? If there are no membranes on the B-scan, most studies and literature suggest waiting 3 months and see what's happening. If it's clearing up, start laser treatment if there's diabetic retinopathy. If it's not clearing up after 3 months, consider doing a vitrectomy. Consider doing anti-VEGF. You know my concerns about anti-VEGF and active diabetic retinopathy, but you can consider doing anti-VEGF if the patient is compliant. Some studies have suggested that the hemorrhages clear up faster with anti-VEGF. And if the patient is using anticoagulants, if it's possible, stop them. If there are membranes on the B-scan, consider doing a vitrectomy sooner rather than later. Normally, if I have a patient with a vitreous hemorrhage and membranes, I normally do anti-VEGF 1 week pre-op and stop the anticoagulants. If there are no neos in the partner eye, of course, I'm coming back to this, consider other causes. If you're in the periphery and you're not sure what you're seeing, if you're not sure, just email or consult with a retinal specialist, ask him how to proceed. Coming back to this, active DRP, tractional membranes, especially when the macula is threatened, do a vitrectomy. It makes no sense if the macula is threatened to do laser first and then send the patient to a retinal specialist, because then by then the macula will have detached and the visual outcome will be much lower. Other treatments. In the last years, a lot of other treatments have surfaced with potential in improving the outcome of diabetic retinopathy. One of those studies was the antiplatelet therapy. Some studies have showed that they reduce the formation of new microaneurysms. The early treatment study shows no effect overall on the diabetic retinopathy process in general. So the verdict is more or less inconclusive still. So it's not necessary to start antiplatelet therapy if a patient has diabetic retinopathy yet, until further studies suggest that it is beneficial. Anti-inflammatory agents. Cytokines like interleukin 1, 6, and 8 increase in diabetic retinopathy. So triamcinolone represses cytokines, but the risk of side effects is there. We know already Kenalog or triamcinolone is being injected into diabetic retinopathy eyes for a longer time already. We know that it helps, but there are also quite a lot of side effects. So until we find an agent that doesn't have the side effects, use it according to your own judgment and when it's deemed safe. Proteins, kinase C inhibitors. Activation of PKC beta may play a role in the pathogenesis of diabetic retinopathy, as they may stimulate VEGF. Studies with, I've always stumbled on this word, ribociclib, showed no significant effect on the progression of diabetic retinopathy. So, yeah, it's not effective enough to really make a difference. Statins. Statins are used a lot nowadays for their vasoprotective and neuroprotective effect and reduction of oxidative stress. Some studies show a reduced visual acuity loss in patients with on statin treatment. So yes, there might be some promise in adding statins to the mix, especially if they have other risk factors and might benefit from the use of statins. Now I'm coming to one point where people who live in Jamaica might get happy. Cannabinoids, marijuana. It has an anti-inflammatory and antioxidant effect. It reduces oxidative stress and blocks VEGF expression. It's very nice. I'm not going to recommend my patient to smoke marijuana yet, but yeah, unless it becomes legal, I think this is nice to know, and unless there are other forms of administering cannabinoids to the eye. Final point is the diabetic mellitus DM cures. Some promising studies are being done right now on islets transplantation, more for diabetes type 1. If transplant, the risk of rejection is quite severe. So they need to be on anti-rejection medication, which is a disadvantage. Some studies now show that some studies have been done with homologous transplant, and these are quite promising already. So let's see what comes up in the future. I think if we wait long enough, some form of cure will be found for diabetes type 1. In conclusion, there are a lot of alternative therapies to prevent or reduce diabetic retinopathies. Nonetheless, laser and anti-VEGF are still the number 1 and 2, not necessarily in that order, being used nowadays. It's not, I think, a modern actual treatment is not either or, it is and. It's both play an important role and can be combined at will. And a very important fact, and I think this is very important here in Vietnam, I've been here 1 year and a half, and I find most people have no clue whatsoever about their general diabetic care. You ask them, what do you eat? Did you change your diet? No, they only take their pills. Their insulin, but they have no change in dietary regime. So I think improvement in this field is crucial here in Vietnam. People should manage their diabetes better, and we will get better results in the eye because of that. One more message. When you have a patient with diabetic retinopathy, with active diabetic retinopathy, be aggressive. If you're too conservative, if you wait too long, the diabetes will not wait for you to treat the eye. It will kill the eye before you get a chance. So be aggressive, treat hard when you have active diabetic retinopathy. These are my data, and this is my email. If you have any questions, if you need advice, or anything about patients with diabetes, you can always send me pictures, send me some data, and I will always answer your email with advice. If you want to scan pictures, please use a PDF scanning app on your phone, which is the easiest way for me to examine your pictures and download them. If you send JPEG pictures, the files might be too large. Thank you. That was my talk.